You so much. Just without further ado, I'll invite the next speaker is Dr. Punam Malik. She's a professor of pediatrics and the Marjorie J. Johnson Chair in Gene and Cell Therapy at Cincinnati Children's Hospital. She's a pioneer in hemoglobinopathies. Her research focuses on pathophysiology of sickle cell disease and beta thalassemias and developing curative gene-based therapies for inherited blood disorders. Today she will be talking about innovations in CRISPR therapies for inherited immune and hematologic disorders. Over to you, ma'am.
Thank you. Thank you for inviting me. I actually have changed the title of my talk. I'm going to review, because I looked at the agenda and there's several people speaking on gene editing. Mitch Weiss is giving a keynote address today, and Jonathan spoke this morning. So I'm going to just review the state of the field of lentiviral gene therapy for sickle cell disease, and talk about what we need, where we should go from there. This is not news to this audience. So gene edition using lentivirus vector has a long track record, over 2 decades actually, since the first lentivirus went into patients. And if the virus is encoded by endogenous promoters, not viral promoters, there has been no incidence of insertional oncogenesis. The downside of having a lentivirus is you need an anti-sickling gene with all its regulatory elements, and the therapeutic gene is permanently transferred to the HSCs. And the other downside is randomly integrates. Over 100 patients, actually it's even more, this is an old slide, have been treated effectively for at least 15 years. There is a small possible risk, but I just alluded to that. And gene editing, on the other hand, uses a target-specific guide RNA to edit the genome, and this is a fix-and-run approach. The technology, although new, shows high efficacy reported in both patients with sickle cell disease and thalassemia. And there is also a possible risk of genotoxicity. The technology is too young, so we don't know that yet. There was similar enthusiasm when retroviral gene therapy cured XKID, and then 5 or 6 years later, we started hearing of insertional oncogenesis. So basically, the premise of gene therapy for sickle cell disease is basically hemoglobin F. And I'm going to give a very brief description here, because this evening, Mitch Weiss is going to talk in detail, and Jonathan has already given you a nice prelude to fetal hemoglobin. So basically, hemoglobin S forms lateral and axial contacts to form the Wishner-Love strand, or the sickle polymer. And hemoglobin F has different amino acids. The gamma-22 alanine disrupts the axial contact with histidine 20, and gamma-87 glutamine disrupts the lateral contact. So these two contacts that I've shown in red, I have a pointer, I guess. Yeah. So these two contacts are disrupted by having fetal hemoglobin. FDA approved 2 gene therapies, and I won't go over those details except for the cost. So this is about $3.2 million per patient. Casgevy is about $2.1 million, I think 2.2, and this is largely unaffordable even in the US. So this is the lentiviral gene therapy. I'm just briefly showing you their efficacy slide. You can see there is a remarkable improvement in vaso-occlusive events. So the red little triangles are the events pre-gene therapy, and post-gene therapy, there were 88% achieved complete resolution. 4 patients in this complete resolution assessment period, which is in that rectangle here. 4 additional patients had VOE, but overall there was 94% complete resolution. These are excellent results. This is Casgevy. Very similar data. Patients had a very high number of vaso-occlusive events, and most patients were VOE free at 12 months. And VOE-free duration was 22.4 months. So safety-wise, there has been one death of a sickle cell patient from cardiopulmonary disease, but this patient had pre-existing pulmonary hypertension. There have been 2 deaths from AML or MDS in the lentiglobin trial, and they have not been due to insertional oncogenesis. 1 death in the Casgevy trial from respiratory failure, secondary to both busulfan toxicity and COVID, and 1 veno-occlusive disease of the liver. However, one has to remember that there is a huge global burden of sickle cell disease, and there are millions of patients worldwide. So we all need to think. So as you probably know that, the Bluebird Bio that pioneered the lentiglobin trial has now been acquired by a private equity group, and it's now changed its name very recently. So we don't know whether they will keep, and this was due to lack of accrual because of the high costs. And these therapies have essentially they've spent years bringing them to the clinic. Casgevy is suffering a similar fate of low accrual, not absent, but low accrual. And this is actually a problem because the company where we had licensed our gene therapy actually folded because they felt Bluebird had gotten the license, so they don't stand a chance. And then Bluebird folded. So this has become the fate for a lot of companies, having gone through all the development. So, and then we need to all think about more affordable and accessible gene therapy, not a boutique gene therapy that's available to the privileged few. So a few things that we can work on, I just listed some of these conditions, and I'll show you data on some of the steps that we are working towards. So the first is efficient stem cell collection and 1 apheresis. Currently, patients require 4 to 6 apheresis or minimum 2 cycles, which is multiple rounds of plerixafor. And this adds to the cost, the patient burden, and the time it takes before they can actually get the infusion. And sickle cell patients have to be transfused before they go through apheresis. Conditioning should be minimally toxic. I've already shown you that most of the side effects that have been seen in the 2 approved therapies have been due to conditioning toxicity. Genetic modification of purified HSC rather than CD34 cells, those are mostly progenitors. Improve homing of gene-modified cells because 3/4 of the infused HSC do not home into the bone marrow. Automated closed systems for genetic modification, and in vivo delivery, which can happen not only with LNP but also with modifications of lentiviruses. So we hypothesize that with reduced intensity conditioning with a single dose of melphalan at a reduced intensity, a high HSC dose, and a potent vector that provides a strong selective advantage to genetically modified RBCs may suffice. And here is a list of all the pros of having reduced intensity conditioning. And the logic was that patients with sickle cell anemia who have persistent mixed donor chimerism after an allogeneic transplant have amelioration of the disease. So we don't really need to fix all their stem cells. So just to show you that, we've recently published this data, so I'm going to really go over it very briefly. We published this paper in July. The duration of thrombocytopenia was only about 5 days, and neutropenia about 8 days. And this is basically what you see when you give outpatient chemotherapy. So we didn't have these patients outpatient because this was first in human, so they were all admitted. And then the other thing we noticed, I'm just picking out some cherry picking from the paper. So we had very average, very modest vector copy number, on average about 0.37 copies because LentiBoost was off limits. It had been acquired by Bluebird Bio. And despite this low vector copy number, just to let you know, in lenti, in the Lyfgenia, they have between 2 to 4 copies per cell. We had just 0.37 copies per cell, and we have a very reasonable amount of this modified fetal globin. I'll go over that in the next few slides. And we had a remarkable improvement. This patient had severe avascular necrosis prior to gene therapy and had a lot of surgical complications from the AVN surgeries. So we were puzzled because this VCN and this level of fetal the anti-sickling beta T87Q globin that Bluebird Bio is using was in their group A patients that had all failed. So the reason why we were successful is because in the G16D mutation that we produced in the gamma globin gene actually increases the functional amount of fetal hemoglobin by about 1.5 to 2-fold. And it was designed to do this. But the other thing we noticed here is that patients mice that got this mutant gamma globin vector actually had much lower retic counts for the same amount of HbF. Or if you look at it here, this amount of this reticulocytosis is much less at a much lower HbF, suggesting that we may even have a higher quality of anti-sickling globin, not just the amount. And when we look at one of our patients, our patients that we treated, the HbF, we were producing 43% HbF G16D per vector copy in patients, and the total HbF was 60%. This is just to show you that we had one of our patients had 16% HbF pre-gene transfer. And when we performed gene therapy a year later, most of this HbF was replaced by HbF G16D. And this patient had no VOEs in the 12 months post-treatment. So this mutation actually changes the 16th amino acid from glycine to aspartic acid, conferring fetal hemoglobin a negative charge. As you all know, alpha globin is positively charged, and beta-like globins are negatively charged, which helps form the tetramer. So if we confer a negative charge to the gamma globin, this was our idea of this mutation, we would actually make much more HbF tetramer because the mutant gamma globin would outcompete the beta sickle globin, which is neutral because the glutamic acid changes to valine, which is the sickle mutation. So we felt we would confer this globin an advantage in forming the tetramer. And that already I've shown you the data. We do form almost 1.5 to 2 times more tetramer. But because we felt we also improved the quality of sickling, we actually did a blinded study where we made identical vectors that only differed by the globin that it was encoding. So this is HbA-T87Q. This is endogenous HbF, and then HbF G16D. Everything else in the vector was identical. And we transplanted mice in 3 large cohorts and selected mice that had very similar anti-sickling globins because our point was just to compare mice with similar levels of anti-sickling globin. So the blue is always the bluebird globin, red is always endogenous HbF, and the green is HbF G16D. So you can see that the hemoglobin increase was identical. The reticulocyte count trended to be lower with G16D. The RBC survival was much higher when mice got HbF G16D. And this is the survival curve based on the level of anti-sickling globin. And the sickling kinetics was actually, with all 3 vectors, the sickling was decreased, but the maximal decrease in the point of sickling occurred with the G16D vector and the membrane deformability. So overall, we felt we have a more potent anti-sickling globin. So based on this, we felt we should now work towards improving homing of the gene-modified HSCs, because we know that we've treated 7 patients and the trial is actually ended now, and we are improving the vector further. So to improve, since most of the cells we infuse are lost in the liver and the spleen and don't make it to the marrow, so we looked at 2 major homing receptors, the CXCR4 CXCL12 axis or VLA4 VCAM. And I'm running out of time, so I won't go over this experiment, but basically we did homing by blocking either of these 2, either CXCR4 or VLA4, and we found that CXCR4 was the major homing receptor for human CD34 positive cells. So we basically developed a transient CXCR4 protein delivery system within lentiviral vectors. So VPR is a HIV protein that's actually very toxic and causes T-cell apoptosis. It's not used in packaging of lentiviruses, but it's been studied to death because it causes T-cell apoptosis, and it's very well defined. Every amino acid that has a deleterious effect, shown in red, has been characterized in detail. So we created a truncated and mutated version of this VPR. I don't have time to show you, but we extensively tested it in progenitors and stem cells and showed that it was absolutely non-toxic. And then we fused this mutant VPR using the HIV protease cleavage site to CXCR4. The reason is VPR latches onto GAG, the matrix protein of lentiviral vector. So this is a regular lentiviral vector, and these are the packaging plasmids that are used to package the vector. If we take a viral-like particle, we remove the genome plasmid, and we add the VPR plasmid. We can see here that we see VPR on the vector-like particles on the surface as we increase the dose. And when we make the vector with the genomic plasmid, we see that it only lasts in CD34 cells for about 48 to 72 hours, and then it's gone. The protein life is over. So this is, to cut the long story short, you can get all the details in the paper we published. We transplanted CD34 positive, HSC-enriched population, transduced either with a GFP lentiviral vector or a GFP lentiviral vector which had this extra packaging plasmid. And we injected the cells either intravenously or intra-bone marrow, and we measured engraftment 6 months later. We have shown that 6 months is a very good time point to study stem cell engraftment. This is the black here is the engraftment of the non-genetically modified cells, the GFP negative, and this is the engraftment of the GFP positive cells. So with IV, just GFP vector, we got a 4-fold increase in engraftment, and with intra-bone marrow, we got a 14-fold increase in engraftment. This is a tremendous, and this is specifically, this increase is only seen in the GFP transduced cells, not the non-transduced cells. So I basically want to emphasize, come back again, that we still have ways to go. We've just improved on the conditioning, and we are working towards improving homing. If we do that, we've done some of the goals that will make gene therapy accessible and less expensive and more doable. And it can also be applied to gene editing, actually. But just to give you an idea, this is a cartogram showing the map of the world and how sickle cell disease distorts the map. So our goal is to make towards accessible, affordable gene therapies, and we are working steadily towards it. So efficient stem cell collection, I think Jonathan alluded to some of this with motixafortide, and Mitch is going to talk to you more about it this evening. conditioning, antibody-based conditioning would be ideal. That can be given outpatient, but that approach also, that company also has enrolled 1 or 2 patients and then folded. So I think melphalan or some other form of non-toxic conditioning would be the goal. Modification of purified HSCs, actually 1 in 100 CD34s is a stem cell. So we're really wasting a lot of reagents, a lot of vector, a lot of gene editing reagents on cells that don't matter. Improving homing, an automated closed system like the Prodigy for efficient, so that the GMP facility use is just removed. And in vivo delivery. So the Seattle group has published that if you package lentivirus with the cocal envelope, it can bypass complement. It cannot be inactivated by complement. You can give it in vivo. Many groups I know are working towards modifying the lentiviral envelope so that it's not recognized by complement, and adding specificity to those envelopes so that they can go and target into the bone marrow. So I think that we all need to work towards all of this. Otherwise, we'll work for 10 years, get a therapy, license it, and it will only treat a few handful of patients. And with that, I want to thank all the people who've done the work. It takes a village, as Bruce Levine had said. This is just a part of the village that I've listed here. And I thank you for your attention.
Thank you so much for that lucid talk. We have time for one question.
High fetal hemoglobin levels. And that is probably said to be one of the reasons why the Indian sickle cell anemia is relatively mild. Now, what you essentially talk about is probably more suited to Europe and America, where you know that even a 3% increase in fetal hemoglobin will work. So in India, you think that these therapies can work. And second is related that you think that a gene editing approach, changing the mutation, will be more practical for contexts like this. Yeah.
That's a very good question. So there are 2 pockets in India. One is in the Gujarat area and one is in the Orissa area. One of them is mild, has high fetal globin, the other one does not. And actually we had the International Conference of Sickle Cell Disease in Orissa, Bhubaneswar, and there we had patients with such severe disease. So there is actually, if you talk to adult providers, there is no mild sickle cell disease. You just see the mildness in children. It just gets, the symptoms get postponed by a decade. And when they are young adults or adults, they have very severe disease. So adult hematologists don't know of the term mild sickle cell disease. In fact, hemoglobin SC disease, which is considered the milder cousin, is also very severe in adults with sickle cell. It's not there, it's from West Africa, the C mutation. So, so that's one thing. The second thing is that high hemoglobin F, we've had patients, as you see, the average hemoglobin F in our patients, the 7 patients we treated, was about 9 to 10%. They still sickle because it's heterogeneous. The same is true with hydroxyurea. You don't get a pancellular expression. And the reason why some patients continue to have a crisis or 2 is because they have 70 to 90% F cells. They don't have 100% F cells. So they continue to hemolyze, they continue to sickle under extreme conditions and have a vaso-occlusive event. So I do think that the correction is ideal, but it's a transversion, A to T, so it cannot be fixed by base editing. You need either prime editing or homology-directed repair. And both of them have not, one of them is too big to deliver. The HDR, you know, I'm sure you know that there was a trial started with correction of the beta globin mutation from Stanford, and after 1 patient, that company folded too. So this is actually a very big problem, that you cannot if it cannot be commercialized, as an academician, you can only treat a handful of patients. You know, the technology has to be commercialized so that it can reach the masses. And if it is commercialized, it should be at a price that is affordable.